Recording in progress.
Welcome everybody and welcome to today's APLAR Ground Round on the complex management of gout. It's a comprehensive approach and it's presented by two early career rheumatologists within the Australian Rheumatology Association. You will have noted that the next Grand Round is on May 25th. So I am your moderator, Kevin Pyle, a Sydney-based rheumatologist. You've looked at some of the housekeeping, but so please keep your microphones muted and submit your questions via the Q&A function and upvote those questions you particularly want answered, and questions will be answered after the second presentation. I'd like to begin by acknowledging the traditional custodians of the land we're meeting on today and pay my respects to elders past, present and future. The two presenters this evening are Dr. Anna Command, who is completing her specialty training in rheumatology this year and is developing her expertise in obstetric medicine relevant to rheumatology. Our second presenter is Dr. Armando Fagel, who is a mid-career advanced trainee in rheumatology. He is passionate and highly skilled in medical illustration and education, and he is focusing his research on improving outpatient management of gout. We have two faculty members. The first is Dr. Ken Kai, a staff specialist at Westmead Hospital and also senior lecturer in rheumatology for the University of Sydney. He is completing his PhD on the link between cardiovascular disease and gout. The second faculty member is Associate Professor Neil McGill from the University of Sydney, who is also an esteemed rheumatologist at the Royal Prince Alfred Hospital. He was the inaugural chair of the Royal College of Pathologists in Australia, their quality assurance program on synovial fluid crystal analysis, and he has held that position for the last 25 years. So with no further ado, I would like to ask Dr. Kermond to present the first presentation.
Hello everyone, my name is Anna Kermond. I'm a final year rheumatology advanced trainee from Brisbane, Australia, currently working out of Royal Brisbane Women's Hospital and Redcliffe Hospital. I just want to start by saying thank you so much for dialing in tonight and for the opportunity to speak. I'd like to start with my acknowledgements. So first beginning with APLAR, thank you very much for having me to speak on the complex gout management tonight. I'd like to also thank the Australian Rheumatology Association for their support in preparing me for my presentation, as well as Associate Professor Neil McGill, who's assisted me in preparing my talk this evening. I'd also like to mention the late Associate Professor Philip Robinson, who was key in me developing my first interest and knowledge of gout management. I also wanted to include here that I know everyone thinks that everything in Australia will try and bite you, and you're absolutely correct. I've included here some photos from my time in Cairns, Australia, with a map here including how large Australia is and how far north it was, whereby I first worked and met this case. I'd like to start by introducing our patient, a 52-year-old male who was first referred to the rheumatology outpatient setting with aspirate confirmed tophaceous gout. His immunological tests were negative and he was initial serum urate of 0.78 at his first outpatient appointment. His medical history was significant for hypertension, but nil else, and his medications at the time of referral were allopurinol 100 milligrams once daily and amlodipine 10 milligrams once daily. Our patient had worked as a chef, but was now unable to work due to the complex morbidity of his gout. He was a non-smoker and no longer consumed any alcohol, although previously was heavy when he was working. Notably, he did have a strong family history of gout, with his father, uncle, and brother all suffering from tophaceous gout as well. I'd like to start by talking about this gentleman's treatment journey. So at time of referral, our patient had significant tophi burden, as you can see here, with tophaceous gout both in his thighs and throughout his toes. He was on allopurinol 100 milligrams at the time, but there'd been no attempts to titrate or educate the patient, and as such, he did have variable adherence. He had a significantly elevated serum uric acid at diagnosis, which did eventually reach target at 0.28 after 9 months of allopurinol titration. However, his tophaceous burden was still significant, and he was unable to work as his hands were required heavily in his line of profession. There's a good talking point to mention at the beginning of our case that just because a patient hits their target serum uric acid doesn't mean that our job as clinicians is done. In the BSR review from 2017, that would advocate a target of less than 0.36 millimoles for gout and less than 0.30 for tophaceous gout. And as we've seen in the literature, the lower the serum uric acid, the faster the tophi resolution. And particularly with this patient facing the social challenges that he did face, an argument was to be made about what was the next step for his management. To start by talking about our options for our patient. So as we know, the next line that we could consider would be uricosuric agents. Other options beyond that was combination therapy of a xanthine oxidase inhibitor and uricosuric agent, uricase therapy, and additional flare prophylaxis, which while not lowering the serum uric acid is part of complex gout management, particularly with someone as large as a tophaceous burden as our patient here. I'd like to start by first talking about probenecid as an option for our patient. So probenecid is a uricosuric agent that primarily binds the URAT1 receptor. However, its binding to OAT is particularly relevant in terms of potential drug interactions. The advantageous features of probenecid include its oral administration, its cost effectiveness, it's well tolerated, and it can be an easy adjunct to xanthine oxidase inhibitors. Considerations and precautions include that anything with twice daily dosing does risk a reduction in adherence, which can be common in our gout cohorts. By way of mechanism, this drug also requires an eGFR of over 30 for effect, with some literature also suggesting an increased risk of liver function derangement with lower renal function and poor clearance. As mentioned, the OAT receptors do have the potential for competitively reduced excretion of drugs, particularly common use drugs such as penicillin, which can lead to toxicities of these items. The increased concentration of uric acid in the tubules does also mean it's important to counsel the patient on adequate hydration and monitoring for signs of potential renal calculi. When considering a uricosuric agent, there is a potential role for calculating urinary uric acid excretion. In my practice, I've typically only seen this done for academic purposes or in some cases to see patients' adherence. It's an option either pre-treatment to decide if it has potential benefit or post-treatment to observe their treatment response. The normal described amount of excreted uric acid is very debated in literature, but the most agreed upon number comes from Harrison's Internal Medicine with the edition from 2018, which mentions that less than 600 milligrams in 24 hours of urinary excretion is regarded as an under-excreter. There were further studies that did demonstrate that a random uric acid to creatinine ratio was roughly equivalent to a 24-hour collection, which is relevant in terms of the ease of collecting 24 hours worth of uric acid in the urine. The next agent I'd like to discuss is benzbromarone. Benzbromarone is another uricosuric agent that binds to the URAT1 receptor. Its effect is typically more potent than probenecid, and it has efficacy in cases that are refractory to xanthine oxidase inhibitors in the literature. It's well tolerated, and the once daily dosing is beneficial, as mentioned before, the minimal interventions as possible. It's notable that it has been withdrawn from some countries due to reported hepatotoxicity, which, whilst rare, the reported toxicity has been severe with acute liver failure reported with initiation. And so to commence the benzbromarone would require monthly LFTs for 3 months and then 3 monthly thereafter as routine. It's worth noting that case series have commented potential cardiovascular benefit by way of reduction in blood pressure and lipid profiles. Reduced renal function is also a consideration with increased monitoring required. However, due to its potency, there is demonstrated uricosuric effect in patients with eGFRs as low as 15 mils per minute. Drug interactions are again a consideration, but this one's more so related to hepatic metabolism rather than renal excretion. In Australia, to use this medication, we would be required to import this therapy, and that would require a special access scheme application. Pegloticase is the next therapy that I'd like to discuss, which does come with its nuances of its own. So pegloticase is one of the 2 known uricase agents alongside rasburicase. As a pegylated agent, this therapy has the considerations of immunogenicity and reactions. Mechanistically, it converts uric acid to allantoin, which is very easily excreted by the kidneys. Its benefits are that it does have its severe or its intense potency as well as its sustained effect, with 2 weeks of pegloticase being associated with reduced serum uric acid. And it does have an association with rapid tophi resolution. Considerations with pegloticase include the immune response and anti-drug antibody formation, which can have an association with infusion reactions and significant cost. In order to use 12 months of pegloticase in Australia from an estimate cost around 2015, the expected cost to the tertiary teaching centre hospital was around $700,000 or 700,000 Australian dollars, which is obviously quite a significant cost for any hospital to absorb. The other consideration is that our long-term safety data is also limited, with very little reporting beyond 6 to 12 months of regular use. Pegloticase immunogenicity is another factor that has to be considered. As mentioned, the pegylated nature does pose an issue for the immune system response. Infusion reactions at baseline first dose are as high as 26%, and loss of response due to anti-drug antibodies currently sits around 25%. It is worth noting that higher percentages of patients have had anti-drug antibodies, but they were of less certain significance, and these patients didn't have loss of effect. With pegloticase therapy, monitoring for anti-drug antibodies is often by proxy, noting that there is an initial drop in the uric acid of the patient, followed by a loss of effect and then rise in serum uric acid. This would then clue the physician that the resistance in anti-drug antibody formation is likely occurring. As a result of this, there are some suggestions to avoid other uricosuric agents that may falsely lower the uric acid, as this may then mask the development of the anti-drug antibodies. They're not only noteworthy in terms of loss of effect to pegloticase therapy, it's also worth that this does significantly increase the patient's risk of reactions, including anaphylaxis. So just to briefly touch on the MIRROR trial, with the immunogenicity of pegloticase posing a significant barrier to treatment, the MIRROR trial from 2021 aimed to demonstrate reduced anti-drug antibody formation with the co-prescription of immunosuppression. This was with low-dose methotrexate at 15 milligrams per week. The goal was to increase patient response as defined by patients achieving a target uric acid for at least 80% of the 6-month treatment window. Indeed, it did show increase in sustained response to pegloticase with methotrexate 15 milligrams weekly, with 78% of patients responding with the co-prescription as compared to 42% monotherapy. There have been other cases that have also tried to demonstrate and replicate this benefit, and that's been with the co-prescription of both leflunomide and azathioprine, although these are in much smaller numbers. I've included a graph here from the MIRROR trial, which nicely demonstrates the potency of pegloticase and its sustained benefit. And this graph demonstrates the patients who were co-prescribed with methotrexate. Combination therapy is our next option for this patient. A literature review from 2019 suggests that only 45% of patients achieve a target serum uric acid with xanthine oxidase inhibitors alone. A review from the same year also nicely demonstrates the significant increased percentage of patients achieving target serum uric acid with combination therapy of allopurinol and benzbromarone. So combination therapy with the discussed agents in my practice has seemed to be an underutilized options. It's not only demonstrated a reduced serum uric acid compared to their monotherapy counterparts, but also faster tophi resolution. It's worth noting that xanthine oxidase inhibitors and uricosuric agents alone don't interact with each other, and there are only few reported cases of liver function derangement that on further analysis were thought to be multifactorial. However, anytime when using a uricosuric agent, other drug actions do need to be considered. Other considerations, anytime that there's more medications, is also consider it pill burden for patients. Anakinra is the last therapy that I'd like to discuss. It's a great therapeutic option for flare prophylaxis when dealing with the typically highly comorbid gout cohort. Its IL-1 blockade is particularly effective in the inflammasome-mediated response of gout, and its localized blockade gives benefit with without the classic prednisone side effects that we'd aim to avoid. Thinking about the gout patients that we all treat, we tend to encounter a lot of diabetics or chronic kidney disease patients, which then makes it more complicated for using things such as prednisone or non-steroidal anti-inflammatories. Its benefits are its potency and its very rapid acting. Other considerations when thinking about anakinra is the potential for injection site reactions and the need for daily dosing with adherence. There is the balance of infection risk. However, if weighed up against the infection risk of using high dose or chronic prednisone use or immobility from gout flares, I feel like this needs to be a relatively weighed up consideration for the clinician. We don't have much long-term safety data on anakinra, and cost is again an issue. I'd like to bring the case back to our patient. So we did initially review whether or not pegloticase therapy would be eligible for this patient. However, due to the cost, this just was not an option for us at the time. The patient did have probenecid 500 milligrams twice daily added to his allopurinol 800 milligrams, and his serum uric acid decreased further to 0.26. And after 18 months of treatment, he did have a resolution of almost 70% of his tophi on clinical assessment. I'd just like to comment that his probenecid dose was relatively low and it can go to a maximum of 2 grams daily. However, this patient was only new in terms of my use of probenecid, and I'm reviewing my presentation and teaching from this data. I would aim to up titrate that further. Was I still involved with his care? I just wanted to include a quote to remind us all how important it is when we're treating patients with gout and how significant the burden is. That our patient mentioned to me that he'd recently been to a wedding where he hadn't seen his family for more than 2 years, and his family couldn't believe how well he looked without any swelling. He was getting ready to apply for another job and a new kitchen, and he felt as though he was getting his life back, which was wonderful to hear from a patient after so much work. So thank you very much for listening to my presentation, and I'd like to hand over to my colleague, Dr. Armando, who will now take you through the second half of our talk. Thank you.
Thank you, Anna. My name is Armando Fagel, and I'm one of the rheumatology advanced trainees here in Australia. And I'm presenting the second case, a case of chronic gout. So I want to introduce everyone to Mr. H. Mr. H is a 52-year-old gentleman that was brought in by ambulance after his daughter found him confused at home. He had a 2-week history of increasing lower limb pain, particularly around his knees, with associated swelling and erythema, increased work of breathing, and fatigue. He was really unable to get out of bed and had urinary and fecal incontinence with little oral intake and poor appetite. His past medical history was significant for chronic tophaceous gout for over 20 years, as well as gastroesophageal reflux disease. When he presented to the emergency department, the medications he was on was colchicine 500 micrograms twice daily and diclofenac, Voltaren gel, which he applies to his joints when he's in pain, as well as a daily multivitamin. He has no family history of gout. In terms of social history, he is of Vietnamese background. He lives alone and has been divorced for several years. Previously, he worked as a delivery driver, but had to stop due to worsening joint pains. He's a non-smoker, does not drink alcohol, or has he ever used any illicit substances. He has a very supportive daughter that lives locally and has really been helping him out with daily household things, especially due to the worsening joint symptoms he's been experiencing. But most of the time, Mr. H is actually independent and is able to do everything himself normally. He is a person that is actually reluctant to seek medical attention, and so doesn't really visit his GP that often. So when he presented to the emergency department, he was obviously unwell. He had bilateral knee swelling, erythema, and tenderness. He had numerous tophi across his hands, elbows, and feet, which I will show photos of soon. Particularly in his lower limbs, he had ulcerations over the tophi. He had chronic venous changes, but had no evidence of peripheral vascular disease in his lower limbs. His cardiovascular, pulmonary, and abdominal examination were all normal. Concerningly, however, he was very hypotensive and was hypothermic to 33.7 degrees. So here are photos of him in the emergency department. And as you can see, he's got tophi really all over his hands, his elbow, and his forearm. And you can also see that there's deformities in the joints of his hands. The next photos of his feet are a lot worse. Straight away, you can see that the feet are unkept. There are tophi, particularly around his ankles, with associated ulcerations. On the top image, you can see tophi coming out of this ulcer, and also a chronic ulcer over his MTP joint. The picture at the bottom shows you a knee that is swollen, red, and very painful. And so all these results are really suggestive that he had sepsis with multi-organ failure. His serum lactate was high, his white cell count was high, and his C-reactive protein was elevated to 150, with evidence of acute kidney injury with a creatinine of 735. He also had mild liver derangement. The blood culture actually grew methicillin-sensitive Staphylococcus aureus quite quickly. And to complicate things further, he actually had bilateral knee septic arthritis, which was aspirate proven. As well, there was evidence of monosodium urate crystals bilaterally. Here are x-rays of his hands in the hospital, and you can see erosive changes really throughout every joint in the hand, his DIPs, his PIPs, MCPs, and his wrists even. And these are juxta-articular erosions, also known as rat bite erosions. The feet, you can also appreciate destructive erosive changes in the phalanx, but also in the midfoot. So Mr. H was admitted to intensive care with sepsis, with multi-organ failure, likely due to the infected ulcerated tophi. He had a lot of complications during his admission. He had septicemia requiring antibiotic, septic arthritis of his knees requiring washout, acute kidney injury requiring dialysis temporarily. The septicemia and the hypotension resulted in him having type 2 myocardial infarction and even ischemic hepatitis and encephalopathy. He was in intensive care for about 31 days before being discharged to the ward. Following stabilization of his condition, the focus of treatment then shifted towards managing his severe chronic gout. He actually was in hospital for about 9 months in total. The time was really for his acute presentation, management of his gout, but also the social circumstances, as he obviously has permanent joint damage and he was unable to look after himself and go back home. At the time of hospital admission, the rheumatology team that were managing his gout started him on urate-lowering agents, and Anna has already talked to you about a number of these agents. But he was started on allopurinol 50 milligrams, up titrated to 900 milligrams daily, with the addition of probenecid, 1 gram twice daily. Instead of pegloticase, rasburicase was used in his case, 3 doses in 3 separate months. And this was used due to the significant tophaceous burden. And the aim was to quickly resolve or dissolve the tophi. And here's just a nice timeline down the bottom telling us that he was in ICU for about a month. And then following ICU, the focus of care was for his gout treatment. The gout prophylaxis that was used included colchicine and prednisone during his hospital stay. And this is a nice graph of his serum urate level over the 9 months in the hospital, from August all the way till May the following year. This yellow line represents the target of urate we want to achieve. In a person like Mr. H with tophaceous gout, the aim would be below 0.3 millimoles per liter. And you can see by the blue line, the urate levels were fluctuating and quite difficult to control, even with high-dose allopurinol, probenecid, and rasburicase. But eventually, towards the end, the target of less than 0.3 was reached. And so where is Mr. H now? Well, he was discharged after 9 months in hospital to a group home. He received National Disability Support Scheme to help him with cooking, cleaning, and really taking care of himself. In terms of his gout, he's had no flares since leaving the hospital, and he's had a significant reduction in tophi burden. He has improved quality of life. And actually, I had the opportunity to talk to him last week, and he shared me some photos of how he's been. And these are some photos of his feet now. And you can see significant reduction in tophi burden and no more ulcerations. In addition to this, here are his hands. Unfortunately, there are permanent joint deformity, but again, resolution of the tophi. Now, that really concludes the case of Mr. H. And the reason why I wanted to share the case with you was to really highlight 2 important points. The first is how poorly managed gout can lead to a lot of complications, including erosive permanent joint damage, as well as tophaceous burden that could lead to ulceration and infection, and in Mr. H's case, ICU admission. The second point I wanted to highlight is that despite good evidence out there for gout management and guidelines, there continues to be poor medication adherence amongst gout patients. And so this is the next point I want to talk about. What are the barriers in treating gout? And there's many literature out there, but really I'd like to divide into two parts, two factors: patient barriers and physician barriers. In terms of patient barriers, the literature says that between 50 to 60% of patients with chronic gout really do not adhere to medication. And these are similar results to an Australian study of 50%. And again, there are a number of reasons why, but it could be easily divided into three factors. The first is there is inadequate understanding of gout for the patients. Gout is typically not seen as a long-term condition. Because of its episodic nature, people don't think it's important to take medications. In addition to this, there might not be enough understanding of the complications associated with gout, such as permanent joint damage and infection. There's also this stigma associated with gout, as gout is often associated with a poor diet, a lot of alcohol intake or alcoholism, and metabolic syndrome, including obesity. And there can be a lot of shame and embarrassment, especially with formation of tophi, to even seek medical attention. Finally, what I think is also very important is the attitudes towards medication. Here, the typical patient are middle-aged men. And so patients don't really want to take medications long-term, especially if it's episodic in nature. In addition to this, patients can also be worried about the side effects and drug interaction. And at least the experience I've had in practice is that a lot of patients do not want to take urate-lowering therapy because they've developed flares when they took it initially. And finally, there's also the financial costs. As this is a long-term medication, there could be financial reasons. Next is the physician barriers. Now, gout is primarily managed in the community by family doctors and GPs. In an Australian study that looked at multiple GP practices, they found that only 50% of gout patients actually see a rheumatologist. And more concerningly, only 22% achieve serum urate targets over 5 years. And there can be a number of reasons for this, including inadequate treatment follow-up and up-titration of urate-lowering therapy, the lack of provider understanding of gout and treatment guidelines, as well as poor education by the doctor to the patient on gout and management options. And obviously, doctors are very busy, and so there's also the time and financial barriers. Knowing these different patient barriers and physician barriers are really important, as it can allow us to develop interventions to help improve medication adherence amongst patients with gout. And so I'd like to talk about some of these interventions that have been published more recently. The first is by Doherty and colleagues in 2018 that really found that nurse-led gout care was better at achieving serum urate concentrations at 2 years compared to GP usual care. 95% of patients achieved serum urate concentration at 2 years with nurse-led compared to 30% in GP-led. Similarly, they found that pharmacist-led education also showed significant improvement in patients reaching serum urate targets, as well as better medication adherence. And this was in part done by regular telephone calls and also the pharmacist calling patients up if they haven't picked up their medications. And so here are my references. And I'd like to, again, thank the Australian Rheumatology Association team, as well as APLAR, for allowing me to present this case. And also Dr. Ken Kai for reviewing my case, and Dr. Ayano Kelly and Brian Liang for allowing me to use this case in particular.
Thank you very much to both of our presenters, and I might ask the panel to perhaps unmute themselves so that they can respond to some of the questions that have been coming through. One of the particular questions has related to when a patient's being titrated, and I might direct it to perhaps Neil McGill to start with. When a patient's titrating up on a urate-lowering agent such as allopurinol, when do you decide that the trajectory has sort of plateaued and they're no longer getting a benefit from any increased dose? And what would you then add subsequently? Would you go to what sort of uricose-uric, or would you go to another xanthine oxidase inhibitor in combination?
Yeah, thanks, Kevin. I think you need to keep measuring it as you increase the allopurinol dose, because you'll find that people plateau and will their serum urate will fail to continue to fall as the allopurinol doses further increase. But that happens at different doses in different people. So almost always there's an extra fall occurs up to 600 milligrams a day, and between 600 and 900, sometimes there's a substantial fall and sometimes there isn't. So what I do is just increase it to 900 and measure how big an extra fall has occurred. If it's actually a trivial fall, then I go back to 600 and add a uricosuric. And which uricosuric I use depends on the person's renal function. So if they've got an eGFR above 30, then I'll use probenecid because it's safer than benzbromarone. If they've got an eGFR that's considerably poorer, then sometimes I'll, if it's a little bit poorer, I'll sometimes still test probenecid, but without much enthusiasm, and then use benzbromarone. I think benzbromarone is an underused drug. I mean, it's relevant when we're talking about these sort of very severe tophaceous gout patients that it reaches some prominence. I'm absolutely not encouraging its use in mild or ordinary gout. That's, the vast majority of those people can be controlled without using a drug that has its risks. Professor Rick Day from Sydney did a wonderful review at looking at the overall danger of benzbromarone compared to allopurinol, and it ends up being about 3 times as dangerous. So your risk of dying from benzbromarone is about 3 times that of allopurinol, and yet we use allopurinol very liberally. And despite knowledge that it has some risks, I think most of us consider it a safe drug. I'm very particular about the monitoring of my patients when they go onto benzbromarone. My patients have weekly blood tests for a month, monthly for 3 months, and then 3 monthly thereafter. And they don't get this next script without the monitoring being done. I've not had a disaster. I have had people develop abnormal liver function tests that quickly came back to normal because they get monitored very quickly, very closely.
Thank you, Neil. Ken, if I may, allopurinol and HLA-B5801 testing has come up. What's your thoughts and practice on that, and where do you use it?
Yep, thanks, Kevin. Look, a lot of it is to do with practicality and access to the test. Unfortunately, depending on where you are, the test may not be readily available or may actually come at a cost to the patient. Here in Australia, it's similar issues in the private versus the public. We know about the association with HLA-B5801, and particularly in Han Chinese, but other population groups within Asia, and including African American also. And certainly in the patients that of that demographic for which I know that they can access the test fairly easily without substantial cost, I do order it. Where it's not available, then certainly I would use more of a lower kind of almost renal impairment approach to urate lowering therapy initiation, starting off at 50 milligrams rather than 100 milligrams, and really carefully monitoring the patient, as well as making sure that they're aware of what, obviously monitoring for rash, but any other side effects from the medication. And so at the moment, it's more of a conditional recommendation for us to test it where available and possible. But certainly in the right demographic group, I would consider it.
Thank you. To any panelist, and whether Armando or Anna wants to have a comment, we've spoken very much about the traditional approaches to urate lowering, but people are often interested in SGLT2 blockade or various statins or antihypertensives. Where does anyone see these fitting in their relative magnitude of effect?
I'm happy to answer that if everyone else, interested in the rest of the panel's thoughts. But from reviewing gout therapies, SGLT2 inhibitors did come up as a therapeutic option. And from what I had seen in 2022, there was a study that looked at this, but the predominant benefit was the duality of the benefit in the highly comorbid patients who did have often concurrent type 2 diabetes. Then that was followed up with a further study in 2023 that then did mention a reduced incidence of gout flares in patients with SGLT2s from a vague uricosuric effect from the glycemic effects with the SGLT2s. I feel like for most of the clinicians in my practice that I've seen, it's mostly swayed that if they are managing their type 2 diabetes, they're going to more so favor an SGLT2 with the multiple options for type 2 diabetic management. But in terms of an isolated treatment or therapy for gout, it's more so a well-supported adjunct to patients who happen to have type 2 diabetes at the time. But interested to hear the other panel's thoughts.
I think they're good comments. You know, I think it depends on whether we're talking about mild or potential gout or preventing gout developing in a subset of people, or we're talking about managing very severe tophaceous gout. You know, I think if you're managing severe tophaceous gout, it has a very small role. But in terms of, you know, if someone's already on allopurinol and they have an SGLT2 inhibitor on board, and they've got a mild uricosuric effect. It's the only, you know, it's a uricosuric that acts through a different mechanism from our conventional uricosurics. You know, almost all of the other uricosurics act on the similar mechanisms, or pretty much the same mechanism, whereas it has a separate mechanism.
Thank you. One of the questions has come up about the management of acute and particularly acute polyarticular gout, and we've seen the use of, or discussed the use potentially of anakinra, but there's obviously financial blockade. So thoughts on prednisolone or colchicine or combinations of colchicine, prednisolone and steroids. Ken, do you want to give us some guidance as to the magnitude of dosing that you would use in these scenarios?
Sure. In terms of the effectiveness, it certainly really very much depends on the individual patient and consideration of their comorbidities, certainly particularly diabetes, or if they have any other issues with fluid retention or cardiac. I normally think about what they've had before. If it's a severe flare, then you're certainly going to need either use of moderate dose prednisone up to about 30 milligrams if you look at the studies, equivalent to an anti-inflammatory or colchicine. But it very much depends on the individual patient and their ability to tolerate the treatment. If they've got a very severe flare, then things are a little bit different. You're considering much higher dose prednisone. In some patients, you may even need to use intravenous methylprednisone. And as discussed as well, the use of anakinra potentially in the acute phase may be very beneficial in those patients that have other comorbidities. Ultimately, these patients do end up requiring hospitalization, sometimes for a prolonged period. And there is data to suggest that potentially if we can use things like anakinra, that may actually be a much more useful approach in order to get them out of hospital sooner, and ideally then onto more effective long-term urate lowering therapy.
So thanks, and I think it's an important point you made about the dose of prednisolone that is often required, and it's often higher than what people may be familiar or comfortable with, because as you allude to, prednisolone 30 to 37.5 is often the equivalent to the anti-inflammatory doses that we use, and there has certainly been an argument to using multimodal therapy using steroids for one action, colchicine for its effect on the inflammasome, and maybe with or without prostaglandins. So there can be multimodal as long as there's not the toxicity. There's been a couple of thoughts. The question just regards comorbidities, in that would you pick allopurinol over febuxostat or vice versa if someone has particular renal disease or hepatic disease? Armando, do you have any thoughts as to what where you see your comorbid illnesses altering your choice for the urate lowering agents?
Yeah.
Or you toss it to one of the colleagues.
Yeah, I guess I could make a comment. My understanding is that allopurinol is probably one of the safest ones to use for people with chronic kidney disease. As to what the maximum dose is, I'm actually not sure. So it'd be interesting to hear what my other colleagues would say. There's also something to note about cardiovascular disease, as there was CARES trials and the FAST trials talking about febuxostat being sort of a concern in patients with cardiovascular comorbidities. I don't know. I'd be interested to hear what the panel think about that, because I think the initial trial that talked about the black box warning for febuxostat possibly is questionable, as a lot of the patients in that trial had significant cardiovascular disease to begin with. In terms of liver impairment, I would have to check that as well. I'm not too sure. I'd like to hear what the other panelists would have to say as well.
Ian, did you want to make any comments, because you've worked in New Zealand and they've undertaken the pivotal sort of work on allopurinol and renal disease, and the starting dose and then the final dose?
Yeah, sure. In terms of renal impairment, certainly it's more to do with the initiation and the risk of developing allopurinol hypersensitivity rather than any precursor or contraindication to a higher dose of allopurinol than what we would consider in a non-renal impairment patient. So certainly in a patient with renal impairment, we start at a lower up titration rate of usually 50 milligrams and go at 50 milligram increments slowly over the period of months, as we would normally do, but in a patient without renal impairment. That's the main concern. And there's good evidence that you can use doses above what a lot of our renal colleagues are comfortable using. The goal is still the same, to get them to below their target serum urate. I wanted to touch a little bit on the cardiovascular aspect as well. I guess that's a really important consideration, particularly with febuxostat. There's been initially a lot of hesitancy around the use of febuxostat in cardiovascular disease following the CARES trial that was published a few years ago now. There's been subsequent follow-up trials to that, including the FAST trial, which was a similar trial in Europe, which didn't actually show an increased risk of cardiovascular disease. And if we go back to the original CARES trial, the concern was that in their secondary outcomes, there was a higher rate of all-cause mortality and cardiovascular events. But to consider with CARES, they recruited everybody that had a past history of cardiovascular disease. And unfortunately, with their study design, only about 45% of patients actually completed the study visits by the end of the actual completed study. In contrast, the FAST study, which is a bit more reassuring, they actually had about 1/3 of their patients that had cardiovascular disease in the past, so the rest did not. And they also excluded patients that had cardiovascular events within the previous 6 months. So there's kind of two different messages there, which is potentially it is safer than we think it is, but I think we still need to tailor it to the individual patient and their cardiovascular risk profile.
Neil, did you have any additional thoughts on that?
No, I agree with Ken. I mean, we need to ask the question as to why would you use febuxostat rather than allopurinol in the first place? So, you could have someone who is HLA-B5801 positive, and I think that would then be a good reason. And the fact that the person had cardiac disease would not dissuade me in that circumstance if they were from an at-risk group. If they'd already demonstrated allergy to allopurinol, again, I'd happily use febuxostat despite a cardiovascular history. But if they don't have either of those things, then I think it's very hard to think of a reason why you would choose febuxostat over allopurinol. And although I think that the studies since CARES have been very reassuring, and I'm now much more at ease in using febuxostat in people with non-cardiovascular disease, I still don't choose it as my first up option of a xanthine oxidase inhibitor, but then again, I don't choose it for people who don't have cardiovascular disease either. Allopurinol is cheap. It's been around for a long time. And if you take away people who are allergic to it or at special high risk of being allergic to it, then I think it's hard to justify using a medication that's about 13 times more expensive. It's still relatively cheap, but nevertheless, ratio-wise, it's more expensive.
And one of the questions has come from some of the countries which are a little bit more resource aware. How often do you think it is, in fact, one of the countries we're alluding to, that they really only have febuxostat or allopurinol? What percentage of patients do you think truly, if they're adherent, do not reach or cannot get close to a target serum urate, either with allopurinol titrated sufficiently, and if that's unsuccessful, with febuxostat titrated appropriately?
Yeah, it's a very small group. One of my team did a study of my patients a few years ago and looked at that. At least 90% of people can achieve their target serum urate just using a xanthine oxidase inhibitor.
Thank you.
And for mine, that was mainly allopurinol. Yeah.
And we haven't really discussed it, but I know you've had previous papers on this subject, Neil. Your thoughts on diet and the magnitude of response that you can get from diet, and whether then maybe Ken or anyone else or Anna and Amanda want to put their thoughts on as well, because it's obviously very vital to patients to know about this area.
Yes, I feel very strongly about the the advice that's given to patients in terms of their diet, potentially setting them up to be failures. If the doctor tells the patient that if they improve their diet, it'll fix their gout, then you can guarantee that the person will fail. So I absolutely encourage patients to lose weight and to stop drinking too much alcohol, because they're both bad for the rest of their health. But I don't for a moment pretend to them that if they fix their diet, that'll fix their gout. So our study that was published and gets quoted in the current American College of Rheumatology guidelines showed that there was an insignificant effect in the patient who already has urate crystals in changing their diet. So by all means, get them to do it for their general health, but don't set them up to be a failure.
I think that's wise words, and I think it's been reinforced by the hypertensive study, the DASH diet, which was incredibly strict and very well monitored. And the magnitude, I think, was something like 0.015 millimoles with that diet. So it was negligible effect, and it was a very difficult diet to maintain as well. So I think you're right for doing it for other reasons. So there's been other thoughts. Ken or Neil, do you ever use anakinra? Where do you see its role? Because someone has asked that specific question. Can you enlighten us about the indication, dose, and how long you might use it during attacks of gout?
You want me to answer that, Ken? I mean,
Yes, if you don't mind.
Yeah, I've not used it very much. I know, Kevin, you use it quite a lot where you work as well, but we've not had the ability to convince our drug committee yet. But you, I think, had more success than we have.
Well, the dose is 100 milligrams a day subcutaneous, and because you're often only requiring it for a relatively short period of time, unlike the vast cost of pegloticase, it's a relatively inexpensive biologic. So, in a rheumatoid patient, we don't hesitate to introduce a therapy that costs $15,000 to $20,000 a year, in the knowledge that'll be required long term. Anakinra costs less than that per year, but you don't need it for a year in the vast majority of these people. You may only need it for a few days, and then there's a small number of people who you might need it for 3 months to get them established on their urate lowering therapy. So I think it's a good agent. And when do I use it? I use it when there's a contraindication to prednisone, colchicine, and non-steroidals. So your diabetic who has impaired renal function and who has sepsis is the typical example. The studies, we don't have great studies in terms of its risk of infection, but those little published series, it seems to be relatively reassuring. And that's been my experience, that it hasn't appeared to cause an extra problem in terms of treating infection. So I feel more relaxed about the use of anakinra than I do about 30 milligrams of prednisone in someone who has sepsis.
And that's been our experience. And the rationale has been that 5 days usage is often our regime, and it's basically shortened our patients, gets them out a day, maybe a day and a half out of hospital quicker, which is a significant saving. And we've had some very prolonged patients with very prolonged polyarticular attacks, and it's allowed them to undertake their physiotherapy and other activities that much quicker. And at the modest cost per day, it doesn't take long to, if you've got an inpatient, to recoup that loss by shortening your length of stay. So I'm just, while I'm thinking of I think, Anna, you alluded to the rate of change of tophi during your talk, particularly when you reach target urate. And people want to get a bit more of a feel for what you think is the realistic time for tophi to dissolve. So again, that we set the patient up to have realistic expectations as to when this change might occur. What's your reading on that?
Well, I feel it's obviously varies a lot patient to patient in terms of their tophi burden and what they're coming into your case with, how much they are debilitated by the tophi. In terms of what is well demonstrated is that the lower the serum uric acid, the faster the tophi resolution. But for patients, it varies wildly. And on preparing for this presentation, what we did note was that the average time of patients for tophi resolution after reaching target with chronic tophaceous gout, chronic being defined as over 5 years, was actually 18 to 24 months. So I feel when I'm speaking to patients about TOFI resolution, I make it very clear from the beginning that it is going to be a journey and that nothing with gout treatment is a quick fix. And to say that as long as they're consistent with their therapy, that eventually things will reduce. But I expectation manage them to say years of treatment before they may see some of their TOFI burden reduce. And I think, on average, most patients had at least 50% of TOFI dissolve when we were thinking about pegloticase or combination therapy at the 12-month mark, but some patients were upwards of 3 years. And obviously that's dependent on what the burden is coming into it. So I guess as a short answer, I prepare them for years of treatment for resolution, but hopefully with target, it's a bit faster than that.
And just following in, a question just popped up in a way. Can you go too low on your serum urate? I think, and what I've noticed so much for patients is more so when patients have been referred with aggressive urate lowering therapy, and they're experiencing mostly problems in terms of muscle cramping as their main side effect, and you look at their uric acid at 0.12. But I mean, I wouldn't really know in terms of long-term adverse effects what that would do to the patient, and be interested to hear Associate Professor McGill's thoughts on that, because we did speak about trying to get our serum uric acid as low as possible for TOFI resolution, but all I've experienced has been cramping and a feeling of general fatigue and malaise.
Well, I think there's we need to think about which patients we're talking about here. So if we're talking about someone who has a little tophus on their toe, then I think the guidelines of getting below 0.30 is appropriate, and we don't need to be pushing very, very low. When it comes to people with, like the cases we've seen tonight, where they have horrendous tophaceous gout, we don't have studies from the literature to help us. So I think we should appreciate that there's uncertainty as to how low is correct. Nicola Dalbeth did a study in 2000, or published in 2021, where they looked at going below 0.30 compared to less than 0.20. And both groups did well, and they weren't able to show a difference between the two groups. But entry into that study was based on having an erosion. So, erosive gout is fairly bad gout, but nothing like what we've seen in our patients tonight. So I think there's uncertainty. I personally, in the people, the type of patient that we saw tonight, I drive it very low, well below 0.20. And I think in that sort of person, the benefits, I believe, outweigh any small risk. Now, once their TOFI have all gone, do I leave them down with a serum urate of 10 or something? A tiny? No, I don't. I ease back on treatment. There remains a question about neurodegenerative diseases with very low urates. I think that we've got as many studies that provide reassurance as concern. But once you've got rid of the TOFI, you don't need a urate to be well below 0.20, so ease back on the treatment. But in the setting of someone having terrible tophaceous gout, I think there's benefit in it being very, very low.
Well, thank you very much for that. And thank you to the panelists for answering those questions so liberally. I might ask our coordinator to take us back to the final slides for this evening. So thank you very much. As I said, we've got some final slides for this evening. Just waiting for it to change. So just reminding you about the APLAR Grand Round Forum. It's the online platform that's associated with the website. We want to hear your comments where you can share your knowledge and exchange ideas. Everyone's invited to write onto the forum, particularly around the themes of the Grand Rounds that you've just attended. And there's the linkage to show you how to find that under the APLAR organisation website. The APLAR Blackboard is also an important function. There have been 2 questions put up about this evening's talk. There are other practical case-based MCQs. There's a detailed answer for the questions, both for this grand round, but also for preceding grand rounds as well. So they're a great learning resource to go back to and hopefully stimulate your thoughts and remind you about the presentation content from today. And like any presentation, this can always be improved. It was really good this evening, but I think we can always improve. So listen, ask you to put your feedback, both either using the QR code or linking through the links that go with the webinar as well. And finally, we'll be bringing up some of the upcoming workshops and grand rounds. Particularly, as I said, the next one in May, the Behçet's disease. Later on, we have osteoarthritis and then osteoporosis to round out this year's presentations. But before we get to the end of the year, we have the APLAR Congress, which is 21 to 25 August. It's in the Singapore Society is hosting it. So please look at the website. I know the abstracts have now opened. Can you please look at registering for your intention and looking at the various options, particularly for trainees, that may facilitate your attendance as well. And so thank you very much. The webinar will end shortly, but if you wouldn't mind putting your hands together or giving your little emojis up through the bottom of the screen for all the effort that particularly Armando and Anna undertook to bring their presentations to you, to Dr. Kai and Dr. McGill for their pearls of wisdom also. Thank you very much. We'll leave you at that.